Hi, this is Dr. Amy Friedman from Live on New York. We are extremely pleased to begin our second webinar today. That's in our series we're calling What's the Deal with Diversity in Organ Donation and Transplantation? And while my own computer has crashed, I'm using my phone to get back in. Carlin will do my slides in a minute. What I would like to do first, after welcoming everyone, is to introduce Dr. Leona Kim, who is going to really give us a lovely little introduction to the this session. And Leona is a well-recognized expert hepatologist, professor of Sydney Zweig Professor of Medicine at the Mount Sinai Hospital, and she's our UNOS Region 9 counselor. So Leona, take it away.
Amy, thank you so much, and welcome to everyone. 2020 has been an unprecedented year of unimaginable events, but with predictable consequences. Some of the events this year has shed light on what I believe has always existed: racial inequality in America. Racial inequality in traffic stops to healthcare delivery, and to what we are here to discuss today, racial inequality in organ transplantation. Nevertheless, despite the anxieties and turmoil these events have brought in 2020, I believe it gives us a unique opportunity to try and fix some of the wrongs in our society. And in order to make meaningful transformations, we need to first acknowledge that there is a problem. We need to embrace changes, and we need to actualize ideas into tangible outcomes. Live On, through the leadership of our board president, Lee Perlman, and his idea to have this symposium, initiated a necessary conversation on the racial inequalities in organ transplantation in the hopes of making it better. We, as New Yorkers, with the most diverse population in a concentrated geographical area, should lead the change in erasing racial inequalities in healthcare. And I'd like to conclude by thanking Helen and Amy for putting this incredible program together. Thank you for the speakers today for their time and efforts. Thank you to Bobby Howard, to Dr. Tangela Purnell, to Dr. Barry Smith, and to Dr. Clive Callender. Dr. Callender, we are deeply honored to have you with us today. Thank you so much for taking the time to join us. Finally, I'd like to end with a quote by the great Dr. Martin Luther King, who said, "The ultimate tragedy is not the oppression and cruelty by the bad people, but the silence over that by the good people." So in the spirit of Dr. King's activism, let us work to be on the right side of history. And with that, Amy, I turn it over to you, and really appreciate all the speakers who are joining us today.
Leona, thank you so much. So that was the photo of Dr. Kim, and she really touched quite a bit on the very, very brief introduction I'm also going to share. The question of why we're doing this webinar series is exactly as she said, that New York State is an important focus of minority affairs. In fact, we have the second largest Black population of any state in the nation. And the vast majority of those African Americans live in New York City and its surrounding counties, which really involves Live on New York. And as she said, it was our board of directors that asked us to do something, and that was the genesis of this webinar series, which we hope is not going to only display and explain the problems that we have and the disparities, but rather come up with some initial practical solutions that we can at least start with. Who are we at Live on New York? Well, we're the organ procurement organization for the New York City, the greater metropolitan area, Long Island, and the lower Hudson Valley. We serve 11 transplant centers and 86 acute care hospitals. So this really is our business, African Americans, disparity in access to donation and transplantation. So what have we planned to do? Well, exactly as you see, this is the second of our webinar series. Today's session is entitled Black Lives Matter in Organ Donation. In our first session, we really dwelled on the disparities on transplantation. Today, we're going to focus on the disparities in organ donation itself. I would be remiss to not thank our Live on New York Foundation for funding this webinar series and being so supportive in every way of the mission of donation and transplantation. I'd like to establish a few ground rules for all of our speakers and any participants. We are hopeful of having respectful discussion that includes, if appropriate, disagreement. We invite disagreement, but we want everything to be respectful. We also are going to be talking about some very sensitive topics. Speak directly about them. Don't tiptoe. Embrace the issue. Certainly, politics are excluded from today's discussion. And I'd like to invite everybody to recognize that if any missteps are taken, they should be addressed respectfully and at the time. And finally, as I noted before, we truly would like to achieve concrete action items. I'm going to remind everybody to please mute yourself unless you are the speaker. We are hearing a little bit of background noise. I also would like to ask our speakers to feel free to join the chat, answer any questions or respond to any comments in real time, because that will make for a much juicier discussion as well. So I'm going to stop sharing, but you see the photo of our next presenter, Dr. Tangela Purnell from Johns Hopkins. And she really is all about Johns Hopkins, which is so exciting. She is a highly awarded speaker, epidemiologist and public health person from Johns Hopkins. She's had a KO1 career development grant from AHRQ. She's the top 40 under 40. And we are really honored to have her participating with us today. And what Tangela is going to speak about is creating a system worthy of Black donation. So Tangela, are you ready to take it away?
I am, and thank you again. It is indeed an honor. In particular, and indeed an honor to see one of my mentors, Dr. Clive Callender, who many of you know, has been really a champion for transplant equity for a very long time, and has mentored many of us who are working in the field today. And so I cannot continue without thanking you for your longtime efforts to do this. Absolutely. And so, you know, I like to jump right into the problem, right? So why are we here? And I'm sure you've talked about this last time. Many of you already know what the problems are, and that's probably why you registered to be here. But just as a reminder, we know that we have a problem here in this country, in many countries. We have a much higher demand for transplants than we have available organs. And so this is a figure from one of the recent SRTR reports, just showing the active candidates on the waiting list for kidney and a liver. As you can see, the majority are waiting for a kidney. And then these are the other organs. So again, this is something that is, you know, important across the board. And we know this is something that impacts the daily lives of so many people who are living with end-stage organ failure, or unfortunately also those who are dying while waiting for an organ. We are here today in particular to talk about what's going on as it relates to disparities in transplants. And so unfortunately, it's a little bit harder to get some of the SRTR graphs and figures by race, ethnicity. And so just sort of as an example, I can show you, you know, for example, the transplant rates per 100 dialysis patient years for deceased donor kidney transplants in the US. And so this is coming from the USRDS annual data reports. And as you can see, the rates, you know, have been pretty much consistent over the last 2 decades. So highest among Asian Americans, followed by white Americans. There's a little bit of some things going on around here, which we know when we really think about the timing of caste, when we think about also the long-term efforts of MOTEP and other groups, we know that we've seen some gains in terms of deceased organ donation among communities of color. And in particular, we know that the most recent allocation changes have definitely helped to address some of the disparities for Black or African American and Hispanic patients, but those are among patients who have to first make it to the waiting list. And so one of the things that we certainly know is that disparities don't begin just on the waiting list. In fact, most of the disparities that patients encounter happen long before they're able to ever get on the waiting list. So similarly, with living donor kidney transplant rates, we see again that white and Asian Americans are more likely to receive a living donor transplant, followed by Native Hawaiian, and at the very bottom, again, Black African American patients. And so this is almost the exact opposite of what we know about who needs transplants. And so again, we have a problem. And so, I just told you about the fact that we have made at least some gains in terms of the disparities among the wait list in who gets a transplant from a deceased donor. And so one of the things that we recently did was really look over time to quantify, potential changes in living donor transplant rates in the US. And so really, our hypothesis was really wanting to answer the question of, well, even if we have not fully eliminated the disparity itself, which we know from the annual reports, have we made any gains at all in at least narrowing the disparity? And so that is sort of what prompted us to do this study, which we published in 2018 in JAMA. And I'll give you the punchline here. No, we have not narrowed the disparity. In fact, the disparity has gotten worse over time, much worse. And so, that was something that obviously was a major headline. But I think for many of us who are working in the field, it just gives us more motivation to work even harder to try and tackle some of these long-standing issues. And so much of what I'm really describing to you today are health disparities, right? And so health disparities, according to the WHO, can be defined as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And where we want to move is a state of health equity, where every person has the opportunity to attain his or her full health potential. And so this is important to talk about within the broader context of where we need to be holistically. We know that many of the factors driving disparities in donation and transplant don't function in a bubble. They're the same factors that are driving disparities in many other conditions and in many other poor health outcomes and lived experiences. And so because we know this, we get to borrow from what we've learned in other fields to try and do an even better job in our own field. So I cannot give this talk without making sure that we're all on the same page when we think about, what is race, as is defined within the national registries and surveys and other major reports and studies where we really highlight many of the key differences. And so what we know is that often what we are reporting is not genetic ancestry. We're not doing genetic ancestry tests and then going in and looking at variations across the board and then doing latent class analysis and grouping people. We're not doing that. What we're doing is actually asking for self-identified or provider-identified race or ethnicity. And what we typically use are the same categories that the US Census uses, and these adhere to the 1997 Office of Management and Budget Standards on race and ethnicity. And so why not go directly to the source? So you can go straight to the US Census website, and they now have a page that starts with what is race. And one thing that I highlighted here is that they tell us very clearly, the racial categories included in the census questionnaire generally reflect a social definition of race, recognized in this country, and not an attempt to define race biologically, anthropologically, or genetically. And so, in addition, we know that people can choose multiple categories, et cetera, including sociocultural groups. And so, in case that's not enough to convince you, we also, I reached out to a couple of the directors of some of the NIH institutes, including those leaders of the National Human Genome Institute and the National Institute on Minority Health and Health Disparities. And what I found out is that they recently had an expert consensus meeting where they tried to come to some resolution on how race and ethnicity data are being used in biomedical research. And really the conclusion was that they said it's time for us to bring everybody together, including genomic researchers, social scientists, medical educators, journals, et cetera. But really the important thing here is when they highlighted the dangers of misinterpreting what we are typically reporting, again, in many of these biomedical studies. And what's highlighted here in red is that they warned us not to perpetuate the myth that race, as we typically measure and define it, is a biological fact. And so I encourage you to also read their 2018 JAMA viewpoint where they discuss this. So back to the story, right? So that was a pivot, but a very important one, because I think that it helps us to really frame all of these factors and what could be going on. So let's think about some of the barriers to organ donation, which ironically or not ironically, for those of us working in this field, are often many of the same barriers that we have to transplant. So again, a few years ago, some colleagues and I, so Dr. Ebony Boulware, who's a mentor of mine at Duke University, and also Dr. Yoshio Hall, who's at the University of Washington, we were asked to essentially conduct a review. So this was a systematic review where we basically wanted to know what were all of the reported barriers to donation in transplant for people who were either trying to be organ donors, so this is from the living donation side, or for people who were in pursuit of a transplant. And what we really found here, which again is very similar to what we know about health disparities in general, is that these factors function on multiple levels. So we were able to create this figure. So we published this, I believe, in around 2012 or 2013. And what we essentially did was we adapted what we know to be the social ecological model of health, a major public health framework. And so from there, we were able to kind of highlight potential factors that were reported in multiple levels, in particular among those patients who self-identified as Black, African American, Hispanic, or Asian American, because that's where most of the research was at the time. And what we know, for example, we can look at the potential transplant recipient or potential donor level. We know that there are differences in terms of clinical suitability and surgical concerns. We also know that there are differences related to medical mistrust or religious concerns. And that, unfortunately, is still a reality, both from the deceased side and the living side, depending on the age of the person being surveyed. But this whole issue of trust, I'll get back to later, because I think one of the things that we really need to again, reframe is not saying that the burden is on the community to automatically trust us, right? So the title of my talk is about creating a system that's worthy of donations. And so again, this issue of trust, you have to first prove trustworthiness, right? And so I think that also speaks to the types of intentional efforts that we need if we know that that's still a major issue. But then we have things functioning at other levels. For example, at the healthcare provider level, we know that communication, whether or not the teams that are approaching families or donors are culturally sensitive, whether or not people have training and education about the most recent advances in the field. We also know that there are things happening at the broader policy level or community level, including differences in insurance coverage or things like chronic disease burden and awareness about the need for donation and transplant across different communities. And so, yet again, we have multiple things going on all at the same time that we have to sort of keep in mind. You are all here, right here in 2012. So that there's a lot going on, right? Including the fact that we are, again, grappling with both, these issues related to overt acts of racism, as well as COVID-19, a major pandemic, right? And so we didn't automatically get rid of all of the barriers to donation or transplant that were functioning prior to this moment. So we now have those factors, in addition to dealing with an entire pandemic and other experiences that could lead to grief, social isolation, again, issues of trust and fear of medical institutions themselves, disrupted access to care, or greater illness and death. So, we think about, these consequences that are being disproportionately burdened by Black and Hispanic patients. We have to really think about, what does this mean if people are now, at least in the earliest stage of this pandemic, dying without their family members being there next to them, thinking about what it means to deal with grief when you aren't able to have proper funerals. So all of these things, and then on top of that, thinking about what it does to our pool of available organs and potential willingness for families to even engage in these types of conversations. So again, really highlighting the need for us to really, work on the things that both tackle the existing problems, but now also pair them with additional unmet needs that this pandemic and our current state of affairs have created, frankly. So I told you I was going to get back to this whole issue of mistrust, right? And where we are currently, in terms of these acts of racism. I think one thing that's important, though, is to really think about the fact that, yes, the easiest thing for us to highlight and point to are these interpersonal acts of racism. It's easy when we see something on social media, et cetera. That's easy to point out, to call out, et cetera. But it's a little bit harder to think about the fact that many of the systems by which this country was built were systematically built in a way that discriminated against entire groups of people. And these systems are not things that we have done a great job of rectifying, even to this day. So for example, what do you mean? One example is we think about housing, right? And we think about the fact that we know that in many places, there are still very segregated neighborhoods. And many of those same segregated neighborhoods often have disproportionate access to economic resources, disproportionate access to healthcare and primary care, which we know is important for building longstanding trust. And also thinking about, relationships with, frankly, our, hospitals and other institutions by which people would experience, being asked for permission to be an organ donor or to donate their family members' organs. And so one example is thinking about how many of these segregated neighborhoods were formed in the first place. And so we think back to, policy and thinking about the practice of redlining, which was literally banks drawing a red line around portions of a map to indicate areas in which mortgage lenders did not want to make loans. Again, we haven't fixed that. And so that's important. But then thinking about things like credit, who gets approved for credit, who is getting approved for homes, who is being portrayed in the media as being deviants, or who's being portrayed in the media as being, worthy. And then thinking about even, things like criminal justice reform and what that means in terms of the pool of available donors, and also just the transplant process itself. And so, this is one of the figures from a paper that, actually one of my earlier papers back, I think in 2008 or 2009, where we wanted to really look at, well, we know that there has been reports in the literature about differences in trust by race, ethnicity for a very long time. We also know that we have an issue in terms of who's willing to disclose intent to donate deceased organs. And the thing that, really prompted this was really having talks with people and realizing that once people really understood the importance of donation and transplant, it wasn't that they were against donating. It was that they had real fears about disclosing that intent to donate. And so one of the things that we really wanted to look at is whether or not there was an association between these types of fears and where people felt most comfortable disclosing their intentions to donate. And so I'm sure this figure is a little busy, but the real punchline here is when we think about, well, who is more likely to say or less likely to say that they completely or mostly trusted their physician or completely or mostly trusted their hospital. But then the opposite of that, who is completely or mostly or most likely to believe that when a person who is an organ donor becomes sick, doctors will try everything to save his or her life. As I mentioned, this is not something from 1954. This is in the 2000s. And we still saw stark differences by race, ethnicity, in terms of thinking, people saying, if I put on my driver's license or a signed organ donor card, then, people won't save my life. But even if people believe that, we wanted to see, well, is there anything else that they would feel comfortable doing? And the surprising thing here is that many of them, if you look here, 92% of African Americans were willing to discuss their intentions with family members or even discuss it with their physicians or religious leaders. What they were not as comfortable doing, again, was publicly disclosing that. And so again, I think that speaks to the nature of unmet or unaddressed fears and what we can do to try and alleviate that, knowing that it's not just a group of people who are not willing to donate. It's a group of people who are concerned about the process of donation and whether or not they would be properly cared for. And so finally, I never like to leave people in a ditch. I never like to say, oh, woe is me. Oh, what are we going to do? This is what we can do, right? And so what are some of the existing initiatives to promote donation and transplant equity? And so first, when we think about directly, interacting with patients or potential donors or families, we think about things like we need culturally appropriate teams and we need sustained community outreach efforts if we're ever going to really promote trust in communities. Point blank, period. We can all go home. That is an important thing that we have to all think about doing. But then again, we have to really improve education and awareness in the broader communities. We have to think about things like whether or not, there are cultural differences in terms of patients' willingness to kind of share their stories outside of their families and close social networks. And then thinking about the use of things like social media outreach, which has become much more popular recently. We know that we've had, longstanding legislation to support living donation, but, perhaps we need to think about revisiting what that means from the deceased side. And then, just again, more holistically, we have different programs at different centers that are really trying to target some of the immunological barriers for people. And then just here, just highlighting some of our ongoing work. So one of the things that I'm doing is really, these studies that really are focusing on partnering with patients, with families, with faith leaders, with community members, and really trying to develop novel strategies that we can co-develop to really tackle some of the disparities in education and social support that's needed to address many of the barriers to donation and transplantation. And I've been partnering with, some of our colleagues here at the Living Legacy Foundation, for example, Latrice Price, who has some existing networks with some of our faith leaders here. And so we've been partnering and doing that. I also routinely go out and give talks, in partnership with them on the radio stations, on, in person at community events. So all of those things are important for, again, building trust. We know that right now, this isn't necessarily the topic that's at the forefront of everybody's minds. But if we are able to help tackle some of the topics that people really want to hear about, that also goes a long way in building trust. And so, again, we know COVID-19 and other things are of importance to many of our communities. And so we've been building these partnerships between some of the investigators and clinicians here at Hopkins and many of the trusted agents in Baltimore to really bridge those gaps so that when we then come back and say things to them like, well, are you willing to let us talk about donation and transplant to your congregation or to your group members, they then won't give us a side eye like, what's in it for you? It's, oh, of course I am, because I've known you for the last 12 years.
On the top left, okay, you see.
And so then, in addition to that, finally, one of the things that we're doing here is thinking more broadly about tackling many of these barriers to promote health equity across the board, and how we can help to train professionals, including, across many fields. And so one of the things that, if you are interested in learning more about, what are some of the key things from health equity research, or, how to apply some of the findings into practice and policy, we now, here at the Johns Hopkins Center for Health Equity, we now have free online courses on Coursera that, you are welcome to take if you're willing and, and available to really do that at your own pace. Our website is healthequityhub.com. And, we also have monthly jam sessions that we call them. So basically seminars where different people talk about different topics. And so again, you can learn more about that. And so, that's really all I have. I think that my charge was mainly to help set the stage for the other two very exciting speakers that we have. But I think that the thing that I would like to leave you with is that, yes, there's something that we can do. No, we don't have time to all be feeling despondent and, feeling like, oh no, woe is me. And we all have an important role to play, and we all have obligations as human beings to do something about these injustices. And so I look forward to working with all of you to tackle these important issues. And thank you again.
Wow, Tangela, that was amazing. But it's not only going to be me to say it's amazing. So I am very privileged to be able to introduce, frankly, a legend, Dr. Clive Callender, who is a son of New York, having gone through the New York public school system and colleges. He returned following medical school to be a professor of surgery at Howard University. In 1973, he returned there. He got his transplant training just under a few minor names, Dr. John Najarian at Minnesota, who unfortunately just passed away, and Dr. Tom Starzl at Pittsburgh. In 1991, Dr. Callender founded MOTEP, the National Minority Organ Tissue and Transplant Education Program. He is frankly considered the senior African-American transplant surgeon and expert in this country, and for that reason has been a highly sought after speaker. And to me, the highlight of all of that is having been on the Oprah show. So without further ado, I'd like to ask Dr. Callender to give a few comments about Dr. Purnell's presentation.
Well, can you hear me?
Yes, we can.
Okay. I've been thrilled once again to hear Dr. Purnell, who eloquently discussed the problems and presented solutions. I have some areas that I highlighted that I think need to be addressed as well. And one of the problems I have with the Census Bureau, and I have had for the last 20 years, is that as far as I'm concerned, race has no place in the Census Bureau. We're all of one race, Homo sapiens. And that's the way it ought to be. We ought to be addressing ethnicity. Is this significant? I think so, because I believe it, we know it's a social issue, and it's a social issue that has been divisive. We need things that are cohesive and put us back together again. So that's an issue that really has been a pet peeve of mine for decades now. For 20 to 30 years, I've been trying to convince not only the Census Bureau, but the National Institutes of Health as well, to understand that what we really are talking about is ethnicity. The group that probably is afflicted and affected even more than the African-American population is the Asian population, because they try to lump everybody together, which is inappropriate. And so among the solutions that Dr. Purnell talked about are issues that relate to us trying to put us together again and have us to eliminate divisiveness. That's one of the ways we can do it. The other thing that I thought was worthy of note is the fact that she mentioned so much about how distrust remains today. It's amazing how some of the very reasons we identified when we first did our work remain today as the reasons for distrust. And the strategies that she's identified are made harder now by COVID because one-to-one is now almost frowned upon, and you have to try to find ways like you're doing today with this webinar to try to reach people to help them overcome distrust. By one-on-one is ideal, but with COVID, it's frowned upon. And so we have to find unique and innovative ways to overcome this obstacle that COVID has presented. Thank you for the opportunity to make comments about the spectacular presentation of Dr. Purnell.
Well, thank you, Dr. Callender. Our next speaker that I'm really privileged to introduce is Bobby Howard. Bobby developed kidney disease and had a kidney transplant years ago, and subsequently dedicated his life to helping others in need with similar problems. He is, I was advised to call him, and this is really perfect, the Director of Family Services Extraordinaire. He is Georgia's, the Director of Georgia's Multicultural Donation Education Program. He has many, many other accolades, among them being a UNOS board member, but the one that I'm kind of, again, finding most fun and intriguing is that he's the president of the Atlanta chapter of NFL former players. So take that. And Bobby, we're glad to have you, and we're going to ask you to speak on Black Lives Do Matter in Organ Transplantation.
Thank you so much for this opportunity. I am so excited about today because, you know, in all of my years of working in this field of donation and transplantation, I am so humbled that we are at this point and at this stage where we can finally and truly talk about what role that Black lives play in organ donation. And so I'm sharing a presentation that I had the opportunity, along with my Ruth Duncan Bell, that we had the opportunity to share at the 27th Annual International Congress of Transplant Society in Spain in July 2018. And also we shared this presentation at the AMAT conference in Las Vegas, Nevada in 2018 as well. Just give you a brief outline of our service area. We do have our OPO here. We do have the whole state of Georgia, which is a population of a little over 10 million now, with the population of 31% from the African-American Black community. We also cover 2 counties in South Carolina, Aiken and Edgefield counties. And as you can see, the overall population, according to the U.S. Census in the United States, hovers around 13, 14, 15%. Our Multicultural Donation Education Program was a program that started in 1994. It started through a grant that was here in Georgia. It was a collaborative grant with Morehouse School of Medicine, Georgia Eye Bank, and Medical College of Georgia. But we, after that grant ended, we decided to keep that program here. So in this study today, what I want to share with you is from the years of a 20-year study of what we've done in the 20 years, and the results during this fall and implementation showed an increase in African-American donors that were more consistent with the population that we serve here in the state of Georgia. And I broke this down in phases so it can kind of make sense. So in our early stages in 1994, when we started this program, as I stated previously, it was a 3-year grant. And in that 3 period, we really concentrated on staff recruitment with the focus on Black health professionals. And in a sense, we really didn't know what we were doing. We looked at Dr. Callender's program in MOTEP and some of the folks that powers the be. We wanted to do things a little differently than what Dr. Callender was doing, but you will see where everything always comes back to where things start off good. You can't ignore those things. It was incorporated into our OPO's operation, and we served as like requesters. Back then, just to clarify what like requesters are, what we were doing here in Georgia, that anytime that there was a referral that was an African-American or Black patient, we sent someone who was African-American and Black to have that conversation and work with that family in the hospital to talk to them about organ and tissue donation. In phase 2 of that program in early 2000, we phased that program out. In the very beginning, the program was great. Our donors were going up and we were doing everything. But the key point that we stopped doing was education. We stopped doing education in the community because we thought that we really had to be in face of every family that was of color, that we needed to provide that opportunity. But we quickly saw a decline. The decline was because we stopped doing education in the community. So we phased this program out and we said, you know, if we really just concentrated on doing community outreach, building community partners, and we hired staff that were culturally sensitive, aware, and had the empathy for people, that we could be successful by implementing a strictly a community outreach program. During that time, we had active recruitment of Black transplant recipients and donor families. We were using materials and documentation that didn't have anyone of color on them. So we changed our mindset. We started using donor families and recipients of color on our brochures. We started bringing them out as volunteers, having them speak on our behalf, and it really increased our outreach within the community. And it goes back, Dr. Purnell talked about trust. We also felt by using people of color to talk in communities of color, that started building a trust within the community. It started building the trust with our churches, with our community leaders, and we went on from there. We also started doing professional partnering, focused on specific registration events, partnering with churches, partnering with civic organizations like the 100 Black Men, the 100 Black Women, all the African-American fraternities and sororities, partnering with our large HBCU congregation here. We got 7 HBCUs here in the state of Georgia. So partnering with those colleges and universities to increase our outreach, to spread the message, not only about organ and tissue donation, but about healthy lifestyles, healthy living. What are some of the effects? What can we do differently so we don't have so many of our people in the need of transplants? We went into phase 3. We saw we were very successful. We had to expand the staff. At one point, I was the only one doing the outreach in the whole state in the African-American community. We had to increase our staff, so we started expanding our staff and in community involvement. And the unique thing, what we did with expansion, we didn't place everyone in Atlanta. We did some geographical research to find out where are our top areas of Black and African-American families living, and we placed those staff strategically. So we have staff in Albany, Georgia, which at that point, their population of African-American in the city of Albany was upwards of 80%. We've had someone in Middle Georgia, considering Macon, with population of upwards of 60%. We had someone in Savannah, Georgia, with a high population. So we really started focusing on those high populated areas, especially in the rural areas in Georgia, where we knew that healthcare and outreach was a struggle for some of those folks in those areas. We revised our donor state registry here in Georgia. We revised some things and start working very closely with our Department of Motor Vehicles, which has since changed to Department of Driver Services here in the state of Georgia. We increased our workplace partnerships, focused on different data points, partnering with schools, partnering with civic groups. We had some things documented. We wanted them to recognize and say that you support organ donation. We support organ and tissue donation, but we did it strategically. We just didn't bring in anyone. It was a strategic plan that we had of trying to get some to the key organizations that we knew that the Black community really had respect for and trust for. So going into our final phase, which starts here in 2013, and I guess I was looking at this today, I said at some point I'm going to have to end phase 4 and start with a phase 5, but I'm going to go into what we did in phase 4. We increased our social media focus. That's what Dr. Purnell just mentioned. We started using not just regular mainstream social media, we started having images of people of like ethnicity. And we really start focusing on those things that were going on with social media. We expanded our staff again with specific target areas. We kept growing because the need was out there. And one of the biggest things that we did in this phase was we started working with our community and legislative partners. We started working with elected officials, the Georgia Legislative Black Caucus. We partnered with them, which we have the largest Black caucus here in the country with over 57 members here in Georgia, that we started partnering with them. We started getting into them because we felt that if you're a leader of that community, if we partner with you, if we also looked at what your need was and looked at what our need was, that you would give us that entree into those communities. And here on this slide here, just giving you some data from 1996 to 2016, a 20-year study that we looked at. We wanted to look at the proportion of African-American donors in the US. They remain consistent, about 16% if you take an average from that time frame, were African-American donors in this country. And as you see, we really relied in this country on our Caucasian donors to provide all the organs for transplantation. And here's it's sort of like the same thing. Now we're going to take a look at what we did here in Georgia with our African-American donor percentage of donors. If you look at 1996, we started 21% of all of the organ donors in the state of Georgia were African-American. And if we jump back to 2016, we were up to 33%, where we had the high in 2015 of 38%. And actually 2009, we had 39% of all of our organ donors in the state of Georgia came from the African-American community. I will keep going back to Dr. Purnell. Everything is built upon trust. Trust in building relationships. And one of the things that we really found out, what we really honed in on, is that we had to realize that our issue with organ donation was not always the first issue when it came to the community. On Monday, it may be somebody else's issue. On Friday, it may have been organ and tissue donation issue. So we had to figure out how we fit into those communities to be able to increase the number of donors that we had here in the state of Georgia that came from the Black and African-American community. Just another chart here to show a comparison of, if you look at the bottom two lines, where you have the solid green line was just showed from the U.S. Census, just the population in the United States of African Americans, which I stated earlier, which hovered around that 13, 14, 15%. And according to the OPTN, that same down at the bottom, that thick blue line there, was the percentage of African American donors in this country, which I stated earlier was around 13, 14%. If we go to the top two lines, that solid green line is the Georgia census of population of African Americans in this state, which come to about 31%. It increased slowly and surely, because in the early 90s, it was only about 25%. So there was an increase in the population of the African American and Black community. And then the squiggly line there, that shows the percentage of the African American and Black donors that we've had over this time period. As you can see, we had our ebb and flow, we were going up and down, and then we kind of hit a point, we were way above with our census and what our population showed here in the state of Georgia. And this next slide will give you a little clear number. And we went back to 2007 when OPTN started looking at OPOs and the number of African-American donors that they were having over the years. So in 2007, we had 74 African-American donors. And then if you look in our closest, the next OPO in the United States at 72. And so in that thick yellow line, you see the slow increase of African-American donors that we've had in the state, which culminates in 2016, we had 102 African-American donors. For a total of that period of time, we had 946 African-American donors in the state of Georgia, and the next OPO comparable to us had 793. So that shows you in that hard work, dedication in the community, building trust, building relationships. If you have that kind of program, you will definitely have an increase in your African-American donors. But it all goes back onto trust, being honest, and providing those communities what they need to be successful. And then what I wanted to add on a little piece, this wasn't a part of the original, but just to show you where we were and how we steadily are continuing with our efforts in the community. In 2017, we had 111, which was a 39% of our overall donors in Georgia. 2018 and 2019, we topped off at 118 with 40% and 34% respectively. So it's still live and kicking. We're doing the same grassroots things. And I go back to Dr. Callender. When I first met Dr. Callender and he had his MOTAP, he talked about the pre and post studies, how you build those relationships. And that's what we had to go back to here in LifeLink of Georgia. We tried to be a little fancy with same race requesting. That didn't work. So we had to go back to what we knew worked in the communities. And that's what Dr. Callender was providing, that opportunities for communities to get involved. And that's what we did here in Georgia. So some of the results in conclusion to close out my presentation. The African-American population increased during the study period from about 27% to 31%. And our percentage of organ donation also increased along with the population to a high of 35% average. Our population of African-American donors exceeded those in our general population for the past decade, during which we had at least 19% more percentage-wise African-American donors over other DSAs nationwide. Our strategy evolved away from was like race requesting donation requesters, as this was noted to not impact the African-American donation And we thought it was, it being fancy, but we had to go back to what we knew worked, and that was truly the education component that we put in place. Survey data indicates here in the state of Georgia, 75% of African Americans in the state of Georgia are willing to be organ and tissue donors, as compared to 52% outside of our service areas here in the state of Georgia, which is a high feat goes back to our education efforts out there in the community. And in conclusion, we feel that the improvement in African American donation rates and increased willingness to donate among African Americans in Georgia, DSA, are directly attributed to the Multicultural Donation Education Program, its periodic evaluations, and the resultant changes in strategies and outreach. And that is the end of my presentation. I thank you guys so much for allowing me to share this, and I hope there is some valuable information that we can take. And just to piggyback off of Dr. Purnell's presentation, and as she stated so eloquently, trust, education are the key. Thank you so much.
Wow, Bobby, thank you so much for an outstanding presentation. Once again, the legacy. Dr. Callender, what are your thoughts?
Spectacular presentation. It's amazing. You go from the optimal presentation of Dr. Purnell to another optimal presentation by Bobby Howard. You know, as an old man, recognizing that almost 30 years ago, I started MOTAP, and 25 years ago got the national federal grant to start MOTAP in 15 sites. And it's just thrilling to see how Bobby Howard has taken that concept of community education and empowerment and love yourself, take care of yourself, and combining intervention with getting people to live healthy lifestyles. And what a difference it's made. And congratulations, Bobby, on a fabulous job.
Our final speaker to be introduced is Dr. Barry Smith. A few minor institutions in his educational pedigree: Harvard, MIT, Cornell, Massachusetts General Hospital, Memorial Sloan Kettering Center. He's served as the Deputy Chief of Surgical Neurology at the NIH, the Director of the Dreyfus Health Foundation, the President and CEO of Rogosin Institute, and is now the President of Applied Medical Research at the Dreyfus Health Policy and Research Center. And the fun fact that I found about Barry is his book entitled New Delta Rising, a tribute to the people of the Mississippi Delta. Now that's a little bit different, so really enjoyed that. So I'm really thrilled to ask Barry to speak to us today. His topic is working at the community level to increase organ donation, whys and hows. So take it away, Barry.
Well, thank you so much for the opportunity to be here today. I feel like the least of all people, having heard the two presentations before, but I will try to tell you what we're doing and the principles behind it. So let's go on to the next slide. I wasn't smart enough to get this to work. We all know about the problem. There are far more people waiting for organ transplants, certainly in New York and around the country, than there are transplants. And how are we going to solve that problem? Next slide. And the challenge has been made greater by the Advancing American Kidney Health Initiative, which was announced just a little over a year ago. Goal: 80% of people with newly developed renal failure will either be on home dialysis or receive a kidney transplant by 2025. And we need twice the number of kidneys by 2030. So for transplantation, how are we going to do that? Next. You know, what do? New York State's a big state. We have we have lots of transplant centers down in one part of the state. We have organ procurement organizations, but we're not covering a lot of ground. But we certainly in New York City have some serious problems. And just to illustrate that, in the next slide, you see from the OPTN kidney data for New York State from 2019, the numbers of deceased donor, living donor, Black, white, Black, Latinx, and Asian transplants. Clearly, we have a long way to go if we're going to be doubling the transplant numbers and making transplantation equitable for everyone. Next. Now, I'm going to focus in today on a particular community. I think our experience in the very diverse city of New York is that different communities differ in their attitudes toward and willingness to donate. One size does not fit all, although we have to shape what we do to fit them. And in particular, I'd like to focus in on Central Brooklyn and East New York in particular as an example of a community with historically low donation rates. What's going on and why is that so? And I think Bobby's already given some answers to that, but we're going to pursue and look at what we're doing next. So next, just next, Carlin, it'll hit the, yeah. There's East New York. The health indices are very poor. Obesity is in the neighborhood of 30%. We're talking about diabetes rates that are 15% compared to 3% in the financial district. Rent burden, you look at a whole number of things, non-fatal assault, hospitalizations, you can see on the right-hand side here are very much higher in East New York and Starrett City, even Brooklyn, but certainly if you look at the lowest and Bayside and Little Neck parts of New York City, they are very, very low. But you know, this does not tell the story of the community. This is a wonderful, vibrant community that has untapped resources and riches that I think can make a huge difference and transform a lot of the rest of New York City, if not beyond the borders there. Next. So one of the things I just want to concentrate on for a few minutes is a community-based and conducted survey that we did. It's now about 3 years old. And I say we didn't do it, the community did it themselves to look at knowledge and attitudes around transplant and organ donation. It was designed by the community. They got out there, they looked at 9,500 people. We used the churches, or they used the churches, community centers, board meetings, housing facilities by community. And let's see some of the things they learned. Next slide. So an awful lot of people had a family connection. Almost a third of families or the people surveyed had a connection to kidney disease. They knew someone who had either was in the family or they knew someone outside the family who had a problem. Next. And they were aware of deceased donation. There were people who said, yeah, it's a good idea to save a life. It's the right thing to do. We want to continue helping others. But other people say, no, wait a minute. I want to be buried whole. I have certain religious beliefs that are against that. I have health issues myself that I don't think would make for a very good kidney. And then something that Tangela and Bobby both brought up, fear of medical professionals, won't try as hard to save me. And this issue of distrust, which is a huge, huge issue. The next slide, let's look at living donation. Reasons in support of living donation, pretty much the same things, but you know, there's fear. What happens if there's something with my other, happens to my other kidney and I am I'm the breadwinner for the family. I can't afford to take that risk, and there are risks associated with surgery, we all know that. Health issues again, and then again, this issue of distrust. But when you look at the percent who were willing to give a living donor kidney, it's up in the 60% range. So we're still missing something here. Next slide. If you look at connection to kidney disease and attitudes to donation, so the people who knew someone in need of a kidney were more likely to be willing, deceased or living donors. That doesn't surprise any of us. Next. So if we put this together, kidney disease is highly prevalent. Almost a third of the families are involved. And I can tell you from going through the dialysis units that are there, this is an enormous problem, and lives are being very negatively affected by the inability to get an organ. So people are very willing to give, and Central Brooklyn is an area of high kidney transplant need, but also is a huge untapped resource for living and deceased donor kidneys. So we talked about the whys and hows. So now there's the why. We've got this wonderful resource, and for some reason it hasn't been tapped. The community needs to be unleashed to do this. So next slide. So how? And then let's hit the next, just hit the return again. So launching a few, we tried, and we worked with Live On New York. We worked with trying to think of the best ways to do this, launched a formal education donor sign up and screening program. That's a priority. It makes sense. But we soon learned that what we proposed to do wasn't enough. It wasn't making a difference in the donation rate. And people were still uncertain about this. Next slide. One of the things that amazed me was when the survey respondents were asked why, given their evident willingness to donate, they thought that the rate of kidney and other organ donation, for that matter, was so low in East New York, Central Brooklyn. They replied, nobody ever asked us before. I thought that was incredible because clearly people had asked them, but the way it got asked or the language that was used on all of our parts, people didn't hear it. And as I think, Bobby, you said, there were other priorities. People weren't thinking just about organ donation. So what do we do? Next slide. Well, we've looked at all the barriers, and you've heard about these several times already today. I don't think we need to go through this again, but look at the very bottom one. Distrust of outsiders, because people were coming into the community and saying, you should give more kidneys. But they weren't people inside that community. And I was at a meeting, this was probably a year ago. One of our advisory councils entirely in the community said, you know, research is basically a dirty word because people have come into this community, they study something, they go away, we never hear about it, and the community never benefits. So this distrust, again, is just a huge issue. But there's another side of it too. Next slide. The potential kidney recipients are a barrier to organ donation and transplantation. This was a survey of 375 patients that were at the Rogosin Institute dialysis clinics. And you look at the issues: fear, dialysis isn't that bad, medical concerns, lack of information, not the right time, worried about wait time, don't have a donor, financial concerns. You go right through the list. And next slide, you see some of the other reasons: the documentation, insurance. These are things you all know about. In some cases, children in the family had volunteered to be donors, but the patient didn't want them to because they were afraid for the family member. Not enough family support for recovery process. Next. And many patients, and this I think is a real tragedy, thought they were on a transplant list, but they weren't. They may have started the process, they didn't continue, they became inactive. And the policy implications of this are great because I think the system is just too complicated. I've had patients sit and ask me, please find out what's wrong. And you go to the transplant coordinator and it is so complicated. I don't think there's any way a patient could ever get through it with their family or without. Next. So I think that increasing organ and particularly kidney donation at the community and grassroots level in East New York, and it may not apply everywhere, requires that what we're asking be an integral part of a broad community-led and driven approach to achieving better health and quality of life. If it's done in isolation, in our experience, it just doesn't work. Next. So to be maximally effective, and you can read the slide because there's only one key word here, which is trust. And I think that the program that we see as necessary in East New York is building a broad multi-sectoral approach to health and quality of life. It's looking at job availability, it's looking at culture, it's looking at language, values, true caring within the community. And unless we put all these things together, we're not going to be as successful as we could otherwise be. And the health professionals, all of us, are part of the problem. Community has tremendous power within it, and that needs to be unleashed to make these changes. Next slide. So what we're putting together is a campaign, and I'll call it that, for better health, and organ donation is a part of that. But I think we're addressing a much broader range of issues because that's what ultimately will make the organ donation more successful. And this campaign is called Rise Up East New York. So it doesn't say, here comes the health professional team. It says, no, the community has this incredible power that needs to be unleashed, and that power will make the changes that need to be made. Next slide. So the mission is mobilizing community residents and bringing together unconventional partners, some of which are large national store chains that are in the area, the bodegas, the barbershops, bringing all these things together. We have representatives from each of these groups. We want to drive local solutions to better health and quality of life that arise from within the community and within the priorities that they see. Next. And just to give you an example, the range of partners we're bringing together, and we have about 20 partners that representing most of these groups now, represent these broad categories, from the houses of faith, the churches, the large businesses like a Target or a Home Depot, small businesses. There are no grocery stores with fresh vegetables, so when we talk about fresh food and vegetables, it's really meaningless. We're linking up with other nonprofits because we don't have expertise. Man Up, for example, is an anti-violence group. We're trying to bring all these other. Brightpoint has been a substance abuse group. We don't have that expertise, but when we put all this together with the unions, the borough president's office, Community Board 5, you can see the whole list, even transportation, public libraries, CUNY, the City University of New York. That's what we need to be doing. And even at the bottom of the list here is the police, NYPD, how we can work with them to change some of the things that discourage people from unleashing that potential that they have. Next slide. And we're building this into what I hope is a lifelong wellness model. It's for kidney health, but it's really much broader than that. So it begins with the health programs we start in school, at home, and young adulthood. Next slide. And remember, this is where organ donation will come out of this, where people are living in this environment that is providing a much broader care. We're also introducing risk stratification with an artificial intelligence program, so that working with the local public health, or public hospital system, I should say, we can work together with them to provide a system which people will have trust in ultimately. Next slide. And this same system continues through mature adulthood and senior adulthood. So we base our interventions on this risk stratification. Who's most at risk? How can we deal the best with them? But again, all of this is community driven. We're putting some pieces together that maybe the community can't do, but unless the community drives it, this won't happen. Next. And that again is about organ donation. I think we can increase organ donation, but this whole system, now this will take some time. So in the meantime, we have to do specific things that will increase organ donation, that will keep people from developing chronic kidney disease, from progressing to end-stage renal disease and ending up in a dialysis chair or in need of a transplant that in New York can take up to 7 years to get one. Next. So that's what I have to say. I think I'm way behind my colleagues, and it's terrific what they're doing, but that's what we're trying to do in working at the community level in East New York. And I believe that this community in East New York has the power to change not only itself, but the power to change New York City. It's an incredibly wonderful and powerful community, but it's never been given the chance to express that, and we want that to happen now. So thank you all very much for the least of all the presentations, but thank you.
Wow, Barry, thank you so much. Really outstanding, especially as a girl who grew up in Brooklyn. I'll turn to, again, our senior African-American transplant surgeon, Dr. Callender. What are your thoughts?
Enjoyed the presentation very much. Community education and empowerment is the key. I think that loving yourself, take care of yourself, and doing all the things that you mentioned are so critical because, as you mentioned, and everyone of the speakers has mentioned, trust is the thing that we have to do. The person, and I've found that the people who have the greatest credibility in the communities are people who are waiting for transplants and people who actually have received transplants and people who have donated. So I think that what you've brought up is something that is very true. Community education and empowerment. It gives you the problem and the solution. Thank you very much for the presentation.
Thank you. Thank you.
Well, thank you. We are left now with about 12 minutes for some questions, and I'm encouraging anybody who has a question to enter it into the chat box. I'm going to start with one basic question, and I think I have the right to ask it. And I'm going to ask each of our speakers and Dr. Callender to give us some thoughts about it, and that is, here I am, an OPO person, organ procurement organization person, very white. What can we as white people do, boots on the ground, to encourage and change this level of mistrust and turn it into trust? So Tangela, if you're available, what are your thoughts?
Sure, happy to get us started, and I'm sure others have many thoughts as well. So first of all, I think that the short answer is there is something that we all, regardless of, our self-identification, can do and must do. We all have to work together. One thing, for example, I think which Bobby highlighted is that, this so-called definition of race alone isn't going to necessarily get rid of centuries and generations of mistrust. So just like someone can, really say, well, I don't trust a system of physicians or OPO professionals across the board, then just having a Black team member alone won't necessarily get rid of that. And so, even as a, white professional, you can still go out into communities. You can still be an advocate. You can do the exact same things that any of us would need to do to establish that we are worthy of the trust of communities. And so, one thing that was interesting here is that when we first started partnering with our faith-based leaders, the first thing that, one of the ministers here asked me was, well, I wanted to know what has been your relationship with this community. I don't want people who come in and just ask us for our organs. And so he had only been living here in Baltimore, I think 4 or 5 years. And I let him know at the time, you know, I've been living here for over 10 years and I've been partnering with churches for almost as long, you know, almost 10 years. And we've been going out. I had to give him my rundown, you know, and he was African-American, I was African-American. And so I think what people want is to know that you are a person who is worthy of trust. And in order to get to that point, I think we all have to do the work that it takes. Sometimes it takes nights, sometimes it takes weekends, sometimes it takes going in and really, you know, like thinking about the things that are important to communities. For example, here, one community neighborhood association wanted to get a grocery store in their neighborhood. So they weren't going to listen at all about Transplant until we had people who cared about what was important to them. And so, you know, that's sort of my response, is doing the exact same things that would necessitate a trusting relationship long term, and not disappearing at the end of, you know, a 5-year project or whatever, because people also make comments about that.
So we have some comments in the chat saying that authenticity and being genuine would really help.
Yes.
Bobby, can I turn to you and ask for your comments, your guidance and recommendations to those of us who are white?
Sure. I think the biggest thing that we have to get away from is someone white feeling that they're not welcome in the Black community and vice versa. And I think once we get over that stigma that the whole Black community is bad and something's going to happen to me, you have to be comfortable in your skin. I can go back to when I first started, and I was told that, Bobby, whoever you talk to when you're working, leave your biases at the door. It doesn't matter what they look like, because we're all human beings, but leave your biases at the door. And if you leave your biases at the door and you go in, you're genuine, and you have concern for the community, you will be just as successful as anyone else, but you can't come in, get what you want, and don't show back up. That is the biggest concern that the Black community has, is that for so long, folks have come to the community, got what they wanted, and they've never come back. So you have to show that commitment, and I think that's what we've done here in Georgia. We've shown the commitment to the community. And when you show the commitment, you will get results, but you just have to show the commitment.
So being devil's advocate, in donation, getting what you want, isn't that getting transplants for your neighbors?
Yes, but what I mean by getting what you want is that you can't go and say, let's use some raw numbers here. You can't go and say, my goal is to get 10 African-American donors. You get your 10, and then you don't show back up. So the commitment is, you can receive what you want, but showing that commitment, don't leave once you reach your goal. What comes after that? So that commitment still lies there, because there's going to still be people being placed on that transplant waiting list on a daily basis. So what do you offer outside of the donation aspect? Are you involved in the programs that are going on at schools? Are you doing other things? Are you showing an interest of what's going on socially in that community as well? So all those things play a role into gaining trust within the community. As I stated earlier, and I always state, our agenda can't be the first thing all the time.
Yeah,
Okay.
and I would say, Amy, that I've come to feel like one of the community in East New York. Now, I'm sure not everybody feels that way, but I have some of my best friends, and I'm most comfortable with the events that they've organized. And, you know, I think, and we're opening in our only office will be in East New York. We're committed to the community, and I think that's important. I love the place.
So Barry, let me put you on the spot. Your office is going to be there. Is it going to be for 1 year, 2 year, 5 years, 50 years?
Well, we're signing up for the long term. What we're saying is we're not coming from somewhere else in New York City. This is our home, and I think, Clive, you said it earlier, we're all Homo sapiens, and Bobby, you said it too. I don't feel any different from anybody else. I'm a little odd looking maybe, but that isn't the issue. These are my friends, and I think when we forget about those color differences, I think we're much better off. And I'm frankly more at home there than I am in parts of Manhattan where I used to feel comfortable. My best friend is called Mr. B, and he's the head of the Alpha Motorcycle Riders Club. But we share a bond, and he's taken young people and taught GED classes for 30 years. And he's taken kids that said, I don't know what I'm going to do with my life, and he's turned that around. That's the kind of people we need to be with, who care. That's I think what I'm saying.
And that's the key. Love. It's all about love. If you really care and you show that you care, people don't care what complexion you are. If you
Right.
love and you truly love and you truly care. Because if you do, then you'll do the things that are appropriate there too, meaning that you'll stay, you'll give, and you'll recognize. For example, with Mocha, what we did, we started a Love Yourself, Take Care of Yourself campaign, meaning that we go to the community. We talk about doing the things that prevent kidney disease in the first place. And then that opens the door so you can talk about anything else that you want. But showing that you love and you care is the most important thing.
So I'm seeing an awful lot of head nodding in the panel of beautiful faces that I see. The question that I would like to pose to you is, what should be said directly to the transplant community? Everybody's sharing the message that this isn't just a transplantation and isn't just a donation issue. It's much broader than that. Broader trust needs to be developed. But what is the message to the donation and transplantation community about how to step forward effectively?
I think it's all about honesty and being transparent. I think sometimes things come up and we're not honest. We want to hide because we feel that it may be offensive or it may not be. I know where I come from. I like folks to be honest and open with me, and then I can make a fair assessment. I think sometimes once we do that and we can learn to move forward and face, okay, it is what it is, but we can make a change. And we can be a part of that change. But we have to acknowledge the things that are there and that are out there. But when we don't acknowledge them and sweep them under the rug, therein lies the problem. So when we acknowledge and openly say, if it's wrong, it's wrong. If it's correct, it's correct. But once we acknowledge, then we can move forward. But if we never acknowledge, we won't move forward.
Anyone else? Tangela, any other thoughts?
Yeah, so along the lines of what Bobby just mentioned, I think one of the things that we have to acknowledge and just be real about is that, unlike many other fields, this field is scary for a lot of people. I mean, let's just call it what it is. First of all, not a lot of people like to talk about dying, period. Sometimes that makes people uncomfortable. They definitely don't want to hear it for the first time when they're about to go in for some type of medical procedure, myself included. And this is my, my field of work. And so really just thinking about the fact that this is something that is scary for some people. And, we have to think about, well, how can we really prove ourselves to be people who are not just in it for what's in it for us, the same thing again. And so one of the things that we've, sort of done is really being supportive of some of the other trusted agents who are already in the community. So there are many ways for us to show a dedicated presence in the community. They don't always have to be sponsored primarily by us. We can be just as present by also partnering with other community events, by also showing ourselves to be friendly and showing up in ways that don't necessarily always start with this particular field. And I think that that's also important because, even in my own experiences, often I lead with the fact that, I'm here on behalf of my role as an associate director of the Center for Health Equity, period. Meaning it's not necessarily specific to any particular disease. And many patients actually hate it, or people hate it when you refer to them as patient, a diabetes patient or a kidney disease patient or whatever. They say we want to be treated as whole people. We want, our experiences as entire people to be recognized and valued, and we want to be heard, and we want people that we can trust to be there for us through all of our challenges in life. And I think that often helps to even start the conversations in a way that doesn't allow people to automatically close off because this is a scary topic for them.
Such powerful words. I think this was a fabulous session. I really am very grateful to all of the speakers who joined us at Live On New York to talk about what is a New York problem. It's also a national problem, but very, very much a New York problem. I've tried to share my screen with you to introduce next week's third and final webinar. It's called People of Color Need Transplants. Let's Cut the Red Tape. And that is solely going to be a moderated session talking about action plans, what we really can do to make this go forward. Again, I want to thank all of our speakers. Wonderful work, really terrific presentations. Thank you to everybody. You will all be receiving a survey by email. Please fill it out. It's actionable information for us, and that's what this whole thing is about, action. Thank you, and what a message of love and trust. Wonderful. Have a wonderful day.